This is a very common question we get asked all the time. Can a tablet or an oral pill deliver the same metabolic effects as an injectable GLP-1?
The best medication for them is one that they're going to be able to realistically be able to take long term.
Hello, colleagues. Dr. Verma here from the Six Health Conversations with Dr. Subodh Verma. We're delighted to welcome Professor Jennifer Green back to the show. We're going to talk today about choices between injectable versus oral GLP-1. This is a very common question we get asked all the time. Can a tablet or an oral pill deliver the same metabolic effects as an injectable GLP-1? Or are we looking at things that are totally different in terms of their potency and strength? So let me turn to you, Dr. Green, welcome you again to the show. Could you provide us with the real answer? Are these interchangeable, or should people be choosing one over the other?
Well, the good news is now that we have many effective choices, and so we're really able to individualize the regimen that we're recommending for each person. And I think that there are very effective oral formulations of GLP-1s that we now have available. So, for example, for a number of years now, we've had an oral formulation of semaglutide called Rybelsus that we have been able to prescribe for management of diabetes. But more recently, the higher dose Wegovy formulation of semaglutide, which again is a daily pill, has become available, which is at a higher dose, 25 milligrams daily. And it is approved for weight management. It's the first such oral formulation approved for weight management. So now we have an effective oral option for people with diabetes and for people without diabetes who would like to lose weight or who have both.
Right. So, I think we still have, individuals who are concerned about needles, right?
Oh, yeah.
And
Oh,
that happens all the time. So I think this really fills a void for individuals who want an alternative, because I've had a few people prior to the advent of the oral therapies walk away, from a GLP-1 when they heard the words for needle, right? And it's reassuring to hear from you that these formulations seem to be relatively interchangeable in terms of how they affect, weight and cardiometabolic risk. So what is the main difference? Is it just that absorption has been a challenge, or, how has science really helped us get a formulation orally now?
yeah, that's a great question. So remember that our stomachs are really good at breaking stuff down, and medications like semaglutide are large proteins or peptides that, if we just swallowed them, essentially would be destroyed by the stomach acid and digestive enzymes. So, in order to generate pill formulations of semaglutide that could be absorbed in therapeutic amounts, they needed to be formulated with an absorption enhancer called SNAC or SNAC. But still, the majority of this oral semaglutide that is taken, even with SNAC, is really it's a tiny proportion of what's actually in the pill. However, the higher dose gets, as you might expect, more of the medication into the system, which is often what is needed for obesity management.
Now, when we think about these medications, they're not just about weight, right? They're about weight and cardiovascular health, metabolic health, kidney health, liver health. They've really transformed, I would say, the entire trajectory of chronic disease in many ways. So would it be reasonable for people to expect the entire cardiometabolic profile to be similar, regardless of whether they take the medication orally or through an injection?
That's a really good question. We do have information about cardiovascular outcomes with oral semaglutide from the SOUL trial. And that was a trial that did show an outcomes benefit, a reduction in cardiovascular risk with use of that oral formulation of semaglutide. And that was the first such trial to demonstrate a cardiovascular outcomes benefit with an oral formulation. Now, whether or not we can extrapolate that to other formulations or other medications entirely, which are available in or will be available in oral form, I can't say. I guess the best I could say is it looks promising from the information that we have available so far. Depending upon your individual risks. Sometimes what I'll do if someone wants to take an oral medication or before we had the outcomes data available for oral semaglutide, it was a medicine that I prescribed to them for diabetes management, weight management, and I made sure, for example, that they were also on another diabetes medicine with a proven outcomes benefit, such as an SGLT2 inhibitor. So I really was checking all of the boxes even before we had the cardiovascular outcomes data from the oral semaglutide trial. So I think there are a lot of different ways to make sure that patients are able to benefit from the particular physiology of the different medicines that they're taking for weight management and or for diabetes management. So this is all manageable. And so, as I've mentioned, so far, everything looks very promising so far about the broader effects, the cardiovascular effects of oral formulations.
Now, Jennifer, some of the higher doses of subcutaneous semaglutide or tirzepatide, those are the only ones that are currently available. But many others are, of course, as you're leading the path for many of these are sort of coming in the future. But the higher doses of agents like tirzepatide, the weight reductions that you're seeing with those therapies, would it be fair to say that they're higher than what you can get with the current available oral therapies, or that's not the case?
Well, we do need to make sure we're comparing, like
Apples to apples, yeah.
Yeah. So, for example, when we look at the weight loss effects of the higher doses of injected semaglutide, so Wegovy, overall in the trials, we see about a 15% mean weight loss over a little bit more than a year. So that's the benchmark. When we look at the effects of the oral Wegovy, 25 milligram dose, in those trials, overall, the average weight loss was 13.6%. So pretty close to what was seen with the injectable formulation. And the good news is that when they looked at the amount of weight that people who were able to stay on the medication, to take the medication consistently, the amount of weight that they lost was much higher, so 16.6%, and some of whom actually lost 20% or more of their total body weight. So I guess the take-home message there is that the weight loss effect of the oral formulation looks to be very effective, and particularly if you're a person who is doing well and can take the medication consistently, you can lose far more than what the average appears to be. So that is key.
I think as you're telling us this, what's going through my mind is the need for individualized therapy and thinking through each patient's desires and wishes around what works best for them, and weighing the overall sort of weight loss goals and adherence goals, etc. But there are other things that also go into the calculus. I've heard from leaders like yourself and others that women tend to lose more weight on these medications, and people living with diabetes tend to lose less weight. So, do those things enter into your algorithm as you're thinking through the choices?
That's a really good question. Maybe not as much as you would expect. It is something that could be discussed with the person. But really, I would say in general, these drugs appear to be beneficial in many different ways for men and women, for people with and without diabetes. So I certainly don't refrain from offering these as a meaningful intervention, for example, to men, even though they may lose a little bit less on average than women do. And people with diabetes, as you have mentioned across trials, lose a bit less weight than people without diabetes, but they may even benefit more from a
From a
cardiovascular risk
cardiovascular standpoint.
perspective. Yeah. So
Exactly. Mhm.
yeah. So I mean, those are things that can be considered and discussed. But it's important to remember that each individual has their own path forward. And I think the most important thing is trying to find a route of administration that the person finds acceptable and can do on a consistent basis, that they're going to tolerate well. And that, again, can be a long term management option for them. So, and now we have so many more options than we have had in the past. It's really rather incredible.
Yeah, that is absolutely true. And you raised a question I was going to ask you around how these therapies, as you said, we've just got a few now, but the pipeline of what's coming for oral GLP-1s is quite rich, and it's exciting. But I think that adherence and compliance to medications long term is the Achilles heel in some cases, right? Because you're only going to derive benefit if people stay on these medications, and therefore finding solutions that sort of really speak to improve adherence cannot be overstated. So, I want you to maybe help us or help the viewers, through that algorithm of how therapies and adherence with either one of those strategies, oral or injectable, is so critical to realize these benefits.
Yes, that's absolutely the case. I think all medications have potential side effects. And these medications, whether they're given via injection or via a pill, most commonly have GI side effects. So, nausea, less likely vomiting, sometimes loose stools or constipation. These are the most commonly reported side effects, although I would point out that the majority of people do not have experienced those problems to any meaningful degree. But in the clinical trials, maybe a quarter of people, maybe a third of people experience those type of side effects, usually not severe. That when they first started the medication, and then there are times when the doses are up titrated when the risk of those side effects either showing up or worsening may occur. The good news is that this is largely a problem early on. And once someone has taken a given dose of a medication consistently, generally those types of side effects are really old history now. They're in the rear view window. They're not all of a sudden going to start later on. We do have to be careful when treatment is interrupted for periods of time. Sometimes people are hospitalized for different reasons and miss many of the weekly doses, and we have to be careful about maybe restarting at a lower dose to ensure that they tolerate that new, essentially, restart of the medication. But as I think I had mentioned on another portion, I'm pretty careful about how quickly I up-titrate doses of these medications, and I like to make sure that the person is really feeling well, that they're not having a lot of stomach upset before I increase the dose further, because that's not going to help matters. I'd rather give it a few extra weeks until things settle down before I increase the dose. So again, it's a little bit of common sense.
No, I do the same. I agree, because it's that step up in doses where you often will see that often transient but important change in side effects. So you want to make sure that you're on the right dose and you're tolerating that. Listen, I've had a wonderful conversation with you. The last 3 episodes have been extremely meaningful. I'd like to first say a huge thank you to you. It's been wonderful to have your insights, your guidance. You've been sort of such an instrumental player in the field, moving the science forward, challenging the science, the science that moves people in the right direction towards more kind of precise and patient-oriented answers. I think this has been a great conversation. And really, if you had to predict the future of where we're headed, we started with G and now double G and triple G and quadruple G and G plus amylin and now oral. The field is becoming difficult for even experts like you and I to sort of keep our hand on the pulse. What do you think the future is going to look like in this area, Jennifer?
Well, again, it's always fantastic to have options. And, maybe it's where I live in the US, but even, for example, some of the most potent medications that we have available now are not enough for some of my patients. And so I'm looking forward to a time when even more potent medications are available. But the good news is that we'll have many more options available in the future. We'll be able to individualize and customize what people take, and find what fits best for them, because the most important thing will be that if someone has an indication for a GLP-1 or GLP-1 like therapy, the best medication for them is one that they're going to be able to realistically be able to take long term and be able to derive the benefits of. So I think the future appears very bright in that respect.
Well said. And that brings us to the end of this episode. It's been great to bring you insights from the real experts in the field. And as you can see, the field is evolving. The field in the future may look very different, but looks very promising. Join us next time on The Six Health so we can make sure we can get you the answers to questions that matter. I'm Dr. Verma.